Good day, and thank you for joining. I am Sherilyn Francis with the National Center for Primary Care, and we welcome you to our Readiness for Adherence webinar series. Today's topic is the incidence and drivers of insulin non-adherence in minority patients. We invite you to connect with us via social media at PriCare Matters and at www.primarycarematters.org. The National Center for Primary Care at the Morehouse School of Medicine promotes excellence in community-oriented primary care health with special emphasis on underserved populations and eliminating health disparities. Our webinar series is brought to you through a partnership with Novo Nordisk. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in serving underserved areas. Our core principles are access, effectiveness, and equity. And now a few housekeeping measures. As participants, your microphones are muted and you shall remain muted through the duration of the presentation. For an optimal audio experience, we encourage you to check your internet connection. During the presentation, we ask that you refer all tech issues to the chat pod, and we ask that you refer all presenter questions to the chat pod. There will be periodic stopping points during each segment for question and answer, and there will be time designated at the conclusion of the webinar for discussion and questions. The objectives for today's webinar are to discuss the incidence and prevalence of medication non-adherence among ethnic minority patients with diabetes, to evaluate the social determinants of health which impact medication adherence, and to analyze attitudinal barriers of clinicians and patients regarding insulin prescribing and therapy adherence. I now present to you today's webinar entitled, The Incidence and Drivers of Insulin Non-Adherence in Minority Patients, presented by Ms. Sabrina Jackson, Ms. Kati Samos, and Ms. Cheryl Tuttle.
Good afternoon, everyone. This is Sabrina. Thanks so much, Sherilyn, for that wonderful introduction. As Sherilyn said, my name is Sabrina Jackson. I'm actually a physician assistant by training. I'm a clinical instructor, faculty member by appointment, and I like to say that I'm a health equity champion by passion and by calling. And so I'm very pleased to be with you today. Thanks so much for having me. What we wanted to try to accomplish today is really to begin a conversation around this idea of insulin non-adherence and some of the drivers, both from a patient and a provider perspective. The entire webinar series will be a 4-series webinar that's occurring between now and March of next year. So we're hoping that those of you who join us today will be sure to come back as we continue the conversation. As we begin with this first slide, which it's a snapshot, and it may not be foreign to most of you out there. I kind of get the idea that I'm preaching to the choir. But this infographic really captures the weight of diabetes today in America. It currently affects about 29.1 million people, which is about 9.3% of the population, 1 out of every 11 people. What's unfortunate is that 1 out of 4 folk don't even know they have diabetes, and that number breaks down to the tune of about 8 million people. Diabetes costs us annually $245 billion. That's looking at lost wages as well as medical costs. It causes 50% more deaths than deaths that come from other diseases or causes, and actually it's the 7th leading cause of death in America. 2 times higher medical costs when compared to other even chronic illnesses, and it's the leading cause of renal disease and non-traumatic lower leg amputations, as well as new cases of blindness in adults. And so this slide really captures the weight of the epidemic that we now face in America through diabetes. Next slide, please. Thank you. This slide, not everyone may be familiar with it. What was kind of funny to me is that in doing research for this, I found a presentation that says, the CDC has now discovered a diabetes belt. as if it is a wonderful discovery. It's sort of a sombering realization, but in 2011 the CDC coined the diabetes belt. It's a segment of the country that represents 644 counties in 15 states. And what it was necessary for the county to make the list is that at least 11% of their population was diagnosed with diabetes. The diabetes belt definition technically is a geographic area in the U.S. where most residents have a 2 times higher chance of developing diabetes. And I want that just to sink in. Diabetes is an epidemic in this country. Next slide, please. And so like with most chronic diseases, however they affect the majority of the population, when they show up in racial and ethnic minorities, the effects tend to be worse. And so this slide simply shows that when they adjust it for population age differences, looking at the National Health Interview Survey and the Indian Health Survey National Patient Information Reporting System, this is looking at adults 20 years or older. We can see that initial statement really being reflected. For non-Hispanic whites, diabetes shows up, these are diagnosed cases, about 7.6%. But when you compare that, particularly with Puerto Ricans, it's almost double. And then looking at non-Hispanic blacks, it's not much better at 13.2%. And then a whopping 15.9% when we look at American Indians and Alaska Natives. Again, this is looking at data from 2010 to 2012. Here we are now 4 years later, and you know the amounts of these statistics, we can surmise it's rising, it's going up. And so this slide kind of helps us transition to what we really want to talk about today, is this idea of insulin adherence. So the benefits of taking insulin and adhering to an insulin regimen is that improved levels of glycemic control, reduced risk of developing both micro and macrovascular complications. Insulin adherence, so taking it well so that it is effective, reduces the risk of all causes of mortality and also reduces the economic burden. You notice I place an asterisk on that statement because then we have to also entertain the whole idea of the cost of insulin in America. We may touch on that a little bit today, won't get off into it, but it can reduce the economic burden of the disease. So looking at hospitalizations, lost wages, and complications from uncontrolled diabetes, but we do have to take into account the unaffordability of insulin for a lot of people in America today. And this is a slide that captures some studies that talk about adherence and showing how adherence to insulin can be a problem. There was a study done by the British Medical Journal from 2016, and it simply states that a substantial portion of people with type 2 diabetes just simply don't take medicine as prescribed. Only 67 to 85% for oral medication, and then approximately 60% of insulin doses were taken properly. I would like to add too that the technical definition of adherence is greater than 80%. And so then there is a study also that I really found fascinating from diabetes medicine. It looked at not only reports from patients but also from their providers. And so it talks about that 32.2% of patients reported omitting their insulin at least one day in the last month, but on the average 3.3 days, when 72% of MDs report that their typical patient just doesn't take their insulin as prescribed. And that was a mean of about 4 days per month for basal insulin, just omitting it, and a little bit more than 5 days a month for prandial insulin. 2010, there was a Cook study that reported that persistence with injectable insulin, so up to a year after initiation, so looking at new patients or patients who were new to taking insulin, only 28% of them, of the ones that were queried, a year later were taking their insulin as prescribed. And then finally, a study that looked at about 11,000, a little bit more, of adult subjects with type 2 diabetes, non-adherence to insulin. So that was defined as less than 80% adherence, measured by, having their medicine occurred in just 21% of subjects. So these studies definitely capture the problem that we're seeing, that people are not taking the insulin as prescribed. And then this is just a nice graphic from a study that was done in Scotland between the years of 95 to 2001 of 1,099 patients, and it gave an average adherence rate of being less than 70%. And so we talk about this issue of insulin non-adherence and looking at, those of us who serve patients underserved, who are racial and ethnic minorities, but also sometimes we do have patients that are Caucasian, and because they live in rural areas, they may have issues with access. And so they technically, even though they may not be a racial or ethnic minority, then they qualify as underserved. And looking at this issue of insulin non-adherence, we understand that there are drivers that lead to this. I always like to say when we start to talk about or mention this term, patients being non-compliant, I often will say, to imagine that when this patient got diagnosed with diabetes 10 years ago, that she never said for her the 10th Christmas after the diagnosis that she would love to have a bilateral amputation for Christmas. That's not what she intended when she got the diagnosis. And so when we see our patients who are not adhering to the regimens, one of the things that I want to encourage us to do is to peel back the layers to begin to explore what's going on with that patient that could be driving them there. Because I can guarantee you that their goal in life is not to die a slow, painful death from diabetes complications. So in looking at just some of the drivers for patients, literature reports things like age, regimen complexity, and then psychological factors. This concept called psychological insulin resistance, which is a theory or an idea, is that both patients and providers can have this thought pattern of these feelings that can lead to them, for patients not wanting to take insulin and for providers not wanting to prescribe insulin. So and then we have other psychological factors like fear and just confusion, feeling like they failed because now they're having to take insulin. Somehow I just couldn't achieve what my doctor wanted me to do, and so now I have to take insulin. I failed at doing a good job of managing my disease. There are issues like safety and tolerability, costs, which we already mentioned, patient-provider interactions. There's something about the relationship between a patient and a doctor or provider that literature actually were able to identify that can lead to medication non-adherence. And then, of course, the social determinants. And the definition that we use for social determinants is the conditions under which that people are born, grow, live, work, and age. So many things in the environment that impact a patient that can affect the way they're able to live out their disease. And then if we go to the next slide, what we're also able to see is that not only do patients play a role in this insulin non-adherence and even adhering to other advice, we look at lifestyle changes and behavioral things that we want our patients to do, then there are drivers for them not doing it. The literature identified a few things too from the provider side. There is this concept, as I mentioned, of psychological insulin resistance, and it comes in the form of biases and fears. Sometimes providers feel like if I suggest this, then my patient is going to resist. They're not going to want to do it, and I just don't want to have to fight with them. My patient is not proficient. It takes a lot of skill to be able to manage insulin in a way that's responsible so that people don't end up with hypoglycemia. And I'm just not sure that my patient is capable, that they're up to the intense monitoring titration that they may need. For some patients, it could be a rocky road getting started on insulin and being able to manage it. And so also fear that this patient is going to cause weight gain, which is going to compound their diabetes as well as make it a problem with their high blood pressure, their cardiovascular disease, and then of course, the hypoglycemia. Also time. I love this picture of the provider in the chair, just frustrated. You're giving me one more thing to do, and I already can't do what you're telling me to do, and now this becomes one other thing. Personnel, I don't have the staff to teach the clients what they really need to know in order to be able to be proficient with their insulin. And then limited knowledge of injection devices for themselves. Things like providers not knowing the right needles to use or the ones that are less painful, and just how to really do it, not having the time to do that kind of training. So these are drivers that even providers bring to the table. And so I just want to remind you, though, that in this changing landscape of healthcare, that now us as providers, we do have a responsibility. We look at now this category 4 that we're entering to 2017 with the implementation of MACRA, this population-based payment. We're now going to be reimbursed for how well our patients do. So population health is here to stay. And we as providers now have to measure health outcomes, and we have to engage our patients. And we're the ones that it falls in our laps on how well our patients do. And so I'm sorry, when I have on my provider hat, I'm right there with you. When I have on my health equity champion hat, then I'm happy for those patients. I'm happy for those folk that are in my family who are underserved and have low literacy level and have to navigate a health system that has, in a lot of ways, has not done them justice. So when we look at population health, you know, it's a balancing act. There's a weight on us as providers, and then there's a weight on the patients, and we've got to figure out how to engage them in their care so that together we can win at this. And at my final slide, it kind of captures it, that when we look at that we do have an issue with medication and other recommendation non-adherent, when we look at our patients with diabetes and other chronic diseases, that we've got to create an environment where we can work together. So that is the solution, finding a way where we put our heads together and come up with a reasonable solution to navigate the barriers. And with that said, I will tag team to the next presenter, Ms. Cheryl Tuttle, who will give us some practical solutions of what she does every single day in trying to work with her patients to engage them and navigate those barriers that they are facing for insulin non-adherence. Thank you.